Sarah Martinez walked through the hospital corridors with her head held high, despite the whispers that followed her everywhere. The fluorescent lights overhead cast harsh shadows across her face, making the scars that ran from her left temple down to her jawline appear even more pronounced. She had grown used to the stares, the quick glances away when people thought she wasn't looking, and the uncomfortable silence that often filled rooms when she entered. As a nurse at St. Mary's General Hospital, Sarah had dedicated her life to helping others heal. It was ironic, she often thought, that someone whose own wounds were so visible would spend her days tending to the hidden hurts of others. The scars that marked her face were reminders of a night 3 years ago that had changed everything about her life, but they had also given her a perspective that made her better at her job than most people realized. That morning, Sarah was assigned to the surgical ward, where she would be working with some of the most critical patients in the hospital. The head nurse, Mrs. Coleman, had pulled her aside earlier with a concerned expression that Sarah had seen too many times before. "Sarah, dear, I need to talk to you about something," Mrs. Coleman had said, her voice gentle but firm. "There have been some complaints from patients and their families about your appearance. They find your scars disturbing. Some have even requested different nurses." Sarah felt the familiar sting of rejection wash over her, but she kept her expression neutral. "I understand, Mrs. Coleman. What would you like me to do? Perhaps you could consider working in areas where there's less patient interaction? The supply room needs organizing, and the paperwork department could use some help." The suggestion hit Sarah like a physical blow. She had worked so hard to get where she was, completing her nursing degree with honors despite the challenges she faced both physically and emotionally. Her scars were the result of a car accident that had claimed the life of her younger brother Miguel, an accident that had left her not only physically marked but emotionally shattered. The months of recovery, the surgeries, the physical therapy, all of it had been bearable because she had a goal. She wanted to help people the way the medical staff had helped her during her darkest hours. "Mrs. Coleman, with respect, I became a nurse to care for patients, not to hide in storage rooms. My scars don't affect my ability to do my job." The older woman sighed, her face showing genuine sympathy but also frustration. "I know you're capable, Sarah. You're one of our best nurses, actually. But this is a business, and we have to consider what our clients want." Before Sarah could respond, Dr. Jennifer Hayes walked by, overhearing the conversation. Dr. Hayes was known throughout the hospital for her sharp tongue and even sharper opinions about what she considered professional standards. "Honestly, Sarah, you really should consider Mrs. Coleman's suggestion," Dr. Hayes interjected, not bothering to lower her voice. "Patients come here to heal, not to be reminded of trauma and injury. Your face is basically a walking advertisement for everything that can go wrong in life." The words cut deep, but Sarah had heard worse. What hurt more was seeing other staff members nearby nod in agreement or simply look away in embarrassment. She had thought that working in healthcare, surrounded by people dedicated to healing and compassion, would be different from the outside world. But human nature, it seemed, was the same everywhere. "I'll think about what you've said," Sarah replied quietly, though she had no intention of hiding herself away. As she walked toward her assigned ward, Sarah reflected on how different her life had become since the accident. Before that night, she had been studying business administration, planning to work in her father's small construction company. She had been confident, outgoing, and, like most young women her age, concerned about her appearance in ways that now seemed trivial. The accident had happened on a rainy November evening. She and Miguel had been driving home from a family dinner when a drunk driver ran a red light and slammed into the passenger side of their car. Miguel had been killed instantly, while Sarah had been trapped in the wreckage for nearly 2 hours before rescue workers could extract her. The metal and glass had carved deep gashes across the left side of her face, and, despite multiple reconstructive surgeries, the scars remained prominently visible. During her long recovery, Sarah had been cared for by a team of nurses who had shown her kindness and compassion that went far beyond their job descriptions. One nurse in particular, an older man named Robert, had sat with her during the darkest nights when the pain medication wasn't enough to dull either her physical or emotional anguish. "Pain changes us," Robert had told her one night when she was crying about how different she looked. "But it can make us stronger, more compassionate. Some people let it make them bitter, but you don't strike me as that type." His words had planted a seed that eventually grew into her decision to change her major to nursing. If she was going to be marked by trauma, she wanted to use that experience to help others who were suffering. She had thrown herself into her studies with determination that surprised even her professors, graduating at the top of her class despite the ongoing surgeries and physical therapy. Now, 3 years into her career, Sarah had to admit that the challenges weren't getting easier. Every day brought new reminders that society judged her by her appearance first and her abilities second. Patients would request different nurses, children would stare and ask uncomfortable questions, and colleagues would speak to her with a mixture of pity and discomfort that made normal workplace relationships nearly impossible. As she entered the surgical ward, Sarah saw that several new patients had been admitted overnight. The first was an elderly man recovering from gallbladder surgery, the second was a young woman who had undergone an emergency appendectomy, and the third was a middle-aged construction worker who had suffered severe burns in an industrial accident. It was this last patient, Mr. David Chen, who would challenge Sarah in ways she hadn't expected. When she approached his bedside to check his vital signs and change his dressings, he took one look at her face and recoiled visibly. "What happened to you?" he asked, his voice a mixture of shock and disgust. "Did you get burned too?" Sarah had developed standard responses to such questions over the years. "I was in an accident a few years ago." "Let's focus on your care, Mr. Chen. How are you feeling today?" But Mr. Chen wasn't satisfied with her deflection. "Listen, no offense, but I don't want someone who looks like that taking care of me. It's depressing enough being here without having to look at, well, you know." The words stung, but Sarah maintained her professional composure. "I understand your concerns, Mr. Chen. Let me get Mrs. Coleman for you." As she walked away from his bedside, Sarah heard him talking to his wife, who had been sitting quietly in the corner. "Can you believe they sent someone like that to take care of me? What are they thinking? I'm already traumatized enough." His wife's response was quieter, but Sarah caught enough of it to understand that she agreed with her husband's assessment. The conversation continued with them discussing how inappropriate it was for the hospital to assign someone with such visible injuries to work with patients who were already dealing with their own medical trauma. Sarah found Mrs. Coleman and explained the situation, watching as the head nurse's face showed the familiar expression of resignation and frustration. It was clear that Mrs. Coleman genuinely liked and respected Sarah's work, but she was also tired of dealing with complaints and uncomfortable situations. "I'll assign Jennifer to Mr. Chen," Mrs. Coleman said, referring to a newer nurse who had started working at the hospital 6 months earlier. "Sarah, why don't you take the patient in room 314 instead?" Room 314 housed Mrs. Eleanor Patterson, an 80-year-old woman recovering from hip replacement surgery. As Sarah entered the room, she braced herself for another potential confrontation, but Mrs. Patterson surprised her with a warm smile. "Oh, hello dear. Are you my new nurse?" "Yes, I'm Sarah Martinez. I'll be taking care of you today." Mrs. Patterson studied Sarah's face with the frank curiosity of someone who had lived long enough to have seen most of what life could offer. "That must have been quite an accident," she said simply. Sarah tensed, waiting for the usual request for a different nurse, but Mrs. Patterson continued in a matter-of-fact tone. "I lost my husband in Korea back in 1953. He came home with scars across his chest and arms from shrapnel. People used to stare at him when we went out, especially in the summer when he wore short sleeves. It hurt him more than he ever let on." The old woman's words were spoken without pity or judgment, just as a statement of fact that somehow made Sarah feel more seen and understood than she had in months. "I'm sorry for your loss," Sarah said, meaning it sincerely. "Oh, he lived for 40 more years after that. The war didn't kill him, old age did." But those scars were part of his story, part of what made him who he was. He used to say that scars were proof that you survived something that tried to destroy you. As Sarah checked Mrs. Patterson's incision and helped her with her physical therapy exercises, the old woman continued to share stories about her late husband and his struggles with being marked by war. It was the first time in months that Sarah had felt like a patient was seeing her as a complete person rather than just a collection of scars. "You know," Mrs. Patterson said as Sarah was preparing to leave, "my husband became a counselor after the war. He specialized in helping other veterans deal with their injuries and trauma. He said his scars gave him credibility with his clients that no medical degree could provide. They knew he understood what they were going through because he bore the evidence of his own battles." The conversation stayed with Sarah for the rest of her shift. She had never thought about her scars as giving her credibility or connection with patients. She had only seen them as barriers to overcome. But Mrs. Patterson's words made her wonder if perhaps she had been looking at her situation from the wrong angle. Later that afternoon, Sarah was called to help with a new admission in the emergency department. A young soldier had been brought in with severe facial injuries from an improvised explosive device that had detonated during his tour in Afghanistan. The soldier, Corporal James Wilson, was conscious but clearly traumatized by what had happened to him. When Sarah approached his bedside, Corporal Wilson looked up at her face and something shifted in his expression. Instead of shock or disgust, she saw recognition and something that looked almost like relief. "You understand, don't you?" he said quietly, his words slightly slurred from the swelling in his jaw. Sarah nodded, feeling a connection with this patient that was different from anything she had experienced before. "I do. It's going to be hard for a while, but it gets easier to carry." As she cleaned his wounds and prepared him for surgery, Corporal Wilson talked about his fears, not just about his physical recovery, but about how people would look at him, whether he would ever be able to have a normal life, whether anyone would ever be able to see past his injuries to the person he had been before. "I can't promise it will be easy," Sarah told him honestly as the surgical team prepared to take him upstairs. "People can be cruel and ignorant. But I can promise you that your worth as a person isn't determined by what shows on the outside." After Corporal Wilson was taken to surgery, Sarah found herself thinking more deeply about Mrs. Patterson's words and her interaction with the young soldier. For the first time since her accident, she began to wonder if perhaps her scars weren't just something to be endured or overcome, but could actually be a source of strength and connection. The rest of her shift passed without major incident, though she continued to notice the usual stares and whispers from other staff members and patients' families. As she was preparing to leave for the day, Dr. Hayes approached her with a clipboard and an expression that suggested she had something unpleasant to discuss. "Sarah, I've been reviewing the patient feedback forms from your ward," Dr. Hayes said, not bothering with pleasantries. "The responses have been quite concerning. Multiple patients have expressed discomfort with your appearance, and several have requested reassignment to other nurses." Sarah felt her heart sink, knowing where this conversation was likely headed. "Dr. Hayes, I understand that some patients may initially feel uncomfortable, but I believe that quality of care should be the primary consideration. Quality of care includes making patients feel comfortable and confident in their healthcare providers," Dr. Hayes replied sharply. "When patients are distracted or upset by a nurse's appearance, it interferes with the healing process." Before Sarah could respond, Mrs. Patterson's voice carried from her nearby room. She had apparently heard the conversation and was calling for Sarah. "Nurse Martinez, dear, could you come here for a moment?" Sarah looked at Dr. Hayes, who nodded curtly, and walked to Mrs. Patterson's room. The elderly woman was sitting up in bed with a determined expression on her face. "Doctor, I couldn't help but overhear your conversation," Mrs. Patterson said, addressing Dr. Hayes, who had followed Sarah into the room. "I wanted you to know that Nurse Martinez has provided me with the most compassionate and professional care I've received in any of my 3 hospital stays this year." Dr. Hayes looked surprised by the intervention. "Mrs. Patterson, I appreciate your feedback, but there have been multiple complaints and there has been multiple praise as well, I imagine," Mrs. Patterson interrupted with the authority of someone accustomed to being heard. "I've been a patient advocate for over 20 years, and I can tell you that technical competence combined with genuine empathy is rare in healthcare. This young woman possesses both qualities in abundance." The conversation was interrupted by a commotion in the hallway. Corporal Wilson had returned from surgery and was experiencing complications that required immediate attention. Sarah excused herself and rushed to assist, leaving Dr. Hayes and Mrs. Patterson to continue their discussion. In the corridor, Sarah found Corporal Wilson conscious but clearly distressed. The surgery had gone well, but he was having what appeared to be a panic attack, hyperventilating and trying to pull at his bandages. I can't do this," he was saying repeatedly. "I can't live like this. I can't let people see me like this." Sarah recognized the emotional crisis that often accompanied severe facial trauma. She had experienced it herself in the weeks following her accident, and she knew that no amount of medical intervention would help if the patient couldn't find a reason to want to heal. "James," she said, using his first name intentionally to create a more personal connection. "Look at me." When he met her eyes, she continued. "I know exactly what you're feeling right now. I know that you're thinking about all the things that will be different, all the ways people will treat you differently, all the fear about whether you'll ever be yourself again." Her words seemed to calm him slightly, his breathing becoming less rapid. "But I also know that you are more than what happened to your face. You are a soldier who served his country, a son, a friend, a person with dreams and goals and things you want to accomplish. Those things didn't change because of your injuries." As she spoke, other staff members had gathered around, including Dr. Hayes, who was watching the interaction with an expression that was difficult to read. "The scars are part of your story now," Sarah continued, "but they're not the whole story. They're proof that you survived something that could have killed you. They're evidence of your strength, not your weakness." Corporal Wilson's breathing had returned to normal, and he was listening intently to her words. "I won't lie to you, it's going to be hard. There will be people who can't see past your injuries, who will make you feel like less than you are. But there will also be people who will see your courage, your resilience, your humanity. And, eventually, if you're lucky, you'll realize that the opinions of the first group don't matter nearly as much as you thought they did." The corridor had grown quiet except for Sarah's voice. Even Dr. Hayes seemed to be listening carefully to what she was saying. "Right now, your job is to heal. Not just physically, but emotionally. Let yourself grieve for the face you lost, but don't forget to celebrate the life you kept." Corporal Wilson nodded slowly, tears running down his cheeks and soaking into his bandages. "Thank you," he whispered. "I needed to hear that from someone who really understands." As the crowd dispersed and Corporal Wilson was settled back in his room, Dr. Hayes approached Sarah with an expression she had never seen before, something that looked almost like respect. "That was impressive," Dr. Hayes said carefully. "I haven't seen anyone connect with a trauma patient quite like that before." Sarah wasn't sure how to respond to what felt like the first genuine compliment she had received from Dr. Hayes in the 3 years they had worked together. "Experience is a powerful teacher," Sarah replied simply. Dr. Hayes studied her face for a long moment, seeming to really see her for the first time rather than just focusing on her scars. "Perhaps we should talk about utilizing your unique perspective more effectively in our trauma care protocols," Dr. Hayes said thoughtfully. "There may be opportunities for you to work more closely with patients who have suffered similar injuries." It wasn't a complete turnaround, but it was progress, and Sarah felt a small spark of hope that perhaps things might begin to change. As she finally left the hospital that evening, Sarah reflected on the day's events. Mrs. Patterson's wisdom, her connection with Corporal Wilson, and even Dr. Hayes' grudging acknowledgement had given her a new way of thinking about her situation. Maybe her scars didn't have to be something she overcame or hid. Maybe they could be something she used to help others heal. Walking to her car in the parking lot, Sarah passed a group of hospital staff members who were heading home after their shifts. She heard fragments of their conversation, speculation about whether she would be reassigned to less visible duties, discussions about patient comfort and hospital policies, debates about whether appearance should factor into patient care assignments. The conversations reminded her that changing a few minds wouldn't immediately transform her entire work environment, but it was a beginning. For the first time in months, Sarah felt like she had allies in her fight to be seen as more than her scars. As she drove home through the city streets, Sarah thought about what Mrs. Patterson had said about scars being proof of survival. She had survived the accident that killed Miguel, survived the months of recovery and rehabilitation, survived 3 years of stares and whispers and rejections. Maybe it was time to stop seeing her survival as something to be ashamed of and start seeing it as something to be proud of. The road ahead was still uncertain, and she knew there would be more challenges, more patients who would reject her care, more colleagues who would see her as a liability rather than an asset. But she also knew now that there were people like Mrs. Patterson and Corporal Wilson who could see past her scars to the person underneath. That night, Sarah made a decision that would change the course of her career and her life. She would no longer apologize for her appearance or hide from difficult situations. She would use her experience, her scars, and her hard-won wisdom to become the kind of nurse she had needed during her own darkest hours. She would be living proof that trauma didn't have to define you, that scars could be sources of strength rather than shame. Little did she know that this decision would soon put her on a collision course with forces much larger than hospital politics and patient complaints, forces that would test everything she thought she knew about courage, service, and the true meaning of honor. 3 weeks later, Sarah's world shifted again when St. Mary's General Hospital received notification that they would be hosting a special delegation of military officials and medical personnel. The visit was part of a new initiative to study civilian trauma care techniques that could be applied to battlefield medicine, and the hospital had been selected as a model facility for the program. The announcement created a buzz of excitement throughout the hospital. Department heads scrambled to prepare their best presentations, ensure their wards were spotless, and select their most impressive staff members to interact with the visiting dignitaries. For most of the hospital's employees, this represented an opportunity to showcase their work to some of the most influential people in military medicine. For Sarah, however, the announcement brought a familiar mix of anticipation and dread. She knew that such high-profile visits typically meant that staff members like her, those who might be considered presentability challenges, would be quietly reassigned to behind-the-scenes duties for the duration of the visit. Sure enough, 2 days before the delegation's arrival, Mrs. Coleman called Sarah into her office with a request that surprised no one who had been paying attention to hospital politics over the past few years. "Sarah, I need you to understand that this visit is extremely important for our hospital's reputation and funding," Mrs. Coleman began, her tone apologetic but firm. "The delegation will include some very influential people, including General Patricia Morrison, who has significant influence over military medical contracts and partnerships." Sarah nodded, already knowing where the conversation was headed. "I'm going to need you to work in the administrative wing during the visit. There's a backlog of patient file reviews that need to be completed, and your attention to detail would be perfect for that kind of work." "Mrs. Coleman," Sarah said carefully, "I understand the importance of this visit, but hiding me away sends the wrong message about what this hospital values in its staff." Mrs. Coleman's face showed genuine conflict. Over the past few weeks, she had witnessed Sarah's exceptional work with trauma patients, including her continued success with Corporal Wilson, who had specifically requested that Sarah remain his primary nurse throughout his extended treatment. "I know you're right, Sarah, but I have to think about the bigger picture. This delegation could bring millions of dollars in research grants and partnerships to our hospital. I can't risk having them focus on anything other than our medical capabilities." Before Sarah could respond, Dr. Hayes knocked on the office door and entered without waiting for permission. Her expression was unusually serious, and she was carrying a thick folder of documents. "I'm sorry to interrupt, but I need to discuss something important about the delegation visit," Dr. Hayes said, then paused when she saw Sarah. "Perhaps this should be a private conversation." Whatever you need to discuss, you can say in front of Sarah, Mrs. Coleman replied, though her tone suggested she wasn't entirely comfortable with the situation. Dr. Hayes hesitated for a moment, then opened her folder. I've been reviewing the materials about the delegation, and there's something I think you should know. General Morrison specifically requested information about our trauma care protocols, particularly our approach to treating patients with severe facial injuries. She pulled out a sheet of paper and placed it on Mrs. Coleman's desk. According to this, one of the primary objectives of their visit is to study how civilian medical facilities address the psychological and social challenges faced by patients with visible injuries. They're dealing with an increasing number of service members returning from combat with facial trauma, and current military medical protocols are proving inadequate for addressing the long-term psychosocial aspects of recovery. Sarah felt a spark of interest despite the uncomfortable nature of the conversation. This was exactly the kind of work she had been hoping to become more involved with. Mrs. Coleman read through the document, her expression growing more thoughtful. This does change things somewhat. But I still think it would be safer to actually, Dr. Hayes interrupted, looking directly at Sarah. I think we should consider including Sarah in the presentations to the delegation. Her work with Corporal Wilson and several other trauma patients has been exemplary, and her unique perspective could be exactly what they're looking for. Both Sarah and Mrs. Coleman stared at Dr. Hayes in surprise. This was the same doctor who had been advocating for Sarah to be moved to less visible positions just weeks earlier. Jennifer, are you sure about this? Mrs. Coleman asked. The risks of not utilizing our best resources are greater than the risks of having to explain why our trauma care specialist happens to have personal experience with facial injuries, Dr. Hayes replied firmly. I've been doing research on trauma recovery protocols, and everything I've read suggests that peer support and lived experience are crucial components of effective treatment. Sarah found her voice. I appreciate Dr. Hayes' confidence, but I want to make sure this isn't some kind of token gesture. If I'm going to be involved, I want it to be because you believe I can contribute something meaningful, not because you think it will look good to have a scarred nurse as a conversation piece. Dr. Hayes met her gaze directly. Sarah, I'll be honest with you. A few weeks ago, I would have agreed with Mrs. Coleman about keeping you out of sight during this visit. But watching you work with Corporal Wilson and several other patients has made me realize that I was thinking about this situation entirely wrong. She paused, seeming to choose her words carefully. In medicine, we talk about evidence-based practice, about using the best available research to guide our treatment decisions. But we often overlook the evidence that comes from lived experience, particularly when it comes to trauma recovery. You provide something that no textbook or research study can offer. You provide hope and credibility to patients who are facing the same challenges you've already overcome. Mrs. Coleman looked between the two women, clearly struggling with the decision. The delegation will be here for 3 days. If we include Sarah in the trauma care presentations, there's no predicting how they'll react. Some military officials can be traditional in their expectations. That's exactly why this could be so valuable, Dr. Hayes argued. Military culture has historically struggled with visible differences and perceived weakness. If we can demonstrate effective treatment approaches that help service members maintain their dignity and self-worth despite facial injuries, it could revolutionize military trauma care. Sarah felt a mix of excitement and terror at the possibility. This could be the opportunity she had been hoping for, a chance to prove that her experience could be an asset rather than a liability. But it could also be a disaster that ended her career at St. Mary's and made it impossible for her to work in healthcare anywhere else. I'll do it, she said quietly. But I want to be clear about something. If I'm going to represent this hospital to military officials, I won't hide my scars or apologize for my appearance. I'll present my work professionally and competently, and if they can't see past my face to appreciate the quality of my care, that says more about them than it does about me. Mrs. Coleman and Dr. Hayes exchanged glances, both recognizing the determination in Sarah's voice. All right, Mrs. Coleman said slowly. But we'll need to prepare thoroughly. I want you to document every aspect of your work with trauma patients, prepare detailed case studies, and be ready to answer questions about your treatment approaches." Over the next 2 days, Sarah threw herself into preparation with an intensity that impressed even Dr. Hayes. She compiled comprehensive reports on her work with Corporal Wilson and 6 other patients who had suffered facial trauma, documenting not just their medical progress but their psychological and social recovery as well. Her reports revealed patterns that hadn't been formally recognized before. Patients under Sarah's care showed significantly faster improvement in their willingness to participate in physical therapy, greater compliance with follow-up treatments, and lower rates of depression and anxiety compared to similar patients treated by other nurses. The data suggested that her personal experience with facial trauma was translating into measurably better patient outcomes. Dr. Hayes worked with Sarah to prepare a presentation that would highlight these findings without sensationalizing Sarah's personal story. They focused on the clinical evidence while acknowledging the role that lived experience played in building trust and rapport with trauma patients. The night before the delegation's arrival, Sarah stood in front of her bathroom mirror, studying her reflection in a way she hadn't done in months. The scars that ran from her temple to her jawline were as prominent as ever, but, for the first time in years, she found herself thinking about them differently. Instead of seeing them as marks of damage, she tried to see them as Mrs. Patterson had suggested, as evidence of survival, strength, and resilience. She thought about Corporal Wilson, who had made remarkable progress over the past few weeks. His physical wounds were healing well, but, more importantly, he had begun to engage with other patients and staff members, demonstrating a confidence that had seemed impossible during his first days in the hospital. When Sarah had asked him about his improvement, he had credited their early conversations with helping him understand that his worth as a person hadn't been diminished by his injuries. "You showed me that someone could have scars and still be whole," he had told her. "That gave me hope that maybe I could be whole too." The next morning, Sarah arrived at the hospital early, wearing her best professional attire and carrying the presentation materials she had spent weeks preparing. The delegation was scheduled to arrive at 9 o'clock, and the trauma care presentations were set for that afternoon. As she walked through the hospital corridors, Sarah noticed the heightened energy that always accompanied important visits. The floors were polished to a shine, every surface had been cleaned and organized, and staff members moved with the careful precision of people who knew they were being watched. In the trauma ward, Corporal Wilson was sitting up in bed, reading a book that his sister had brought during visiting hours the previous evening. When he saw Sarah approaching, he smiled, something that had become increasingly common over the past few weeks. "Good morning, Sarah. You look nervous. Is this about the big visit everyone's been talking about?" Sarah nodded, feeling grateful for his directness. "I'm going to be presenting some of our trauma care work to a delegation of military officials this afternoon. I'm a little anxious about it." Corporal Wilson studied her face with the understanding of someone who had learned to read beyond surface expressions. "Are you worried about how they'll react to your scars?" "That's part of it," Sarah admitted. "But I'm also worried about whether I can adequately represent the importance of this work. This could be an opportunity to change how military medical facilities approach trauma recovery, and I don't want to mess it up." "Sarah," Corporal Wilson said seriously, "you changed my life by being willing to share your experience and show me that survival was possible. If you can do that for one messed up soldier, you can do it for an entire room of generals and doctors." His confidence in her was both inspiring and intimidating. Sarah knew that the afternoon's presentation would be one of the most important moments of her career, but she also knew that she had something valuable to offer, not despite her scars, but because of the journey that had created them. At noon, the delegation arrived at the hospital for a tour of the facilities. Sarah watched from the trauma ward as the group moved through the corridors, led by Mrs. Coleman and the hospital's chief administrator. The delegation included several high-ranking military officers, medical researchers, and civilian contractors, all taking careful notes and asking detailed questions about the hospital's operations. General Patricia Morrison was immediately recognizable, a tall, distinguished woman in her 50s whose bearing and manner commanded respect from everyone around her. She moved through the hospital with the focused attention of someone accustomed to evaluating complex operations and making critical decisions based on limited information. As the group approached the trauma ward, Sarah felt her heart rate increase. She had been assigned to conduct her normal patient care duties during the tour, which meant there was a strong possibility that the delegation would see her interacting with patients before the formal presentation that afternoon. The delegation entered the ward just as Sarah was helping an elderly patient with his physical therapy exercises. She was acutely aware of their presence but forced herself to focus on her patient, explaining each movement and providing encouragement as he worked to regain mobility after hip surgery. "Excellent range of motion, Mr. Peterson," she said as he completed a series of leg lifts. "You're making remarkable progress. At this rate, you'll be back to walking your dog around the neighborhood within a few weeks." Mr. Peterson beamed at the praise, clearly proud of his improvement. "This young lady has been wonderful," he told the delegation members who had gathered nearby. "She never lets me give up, even when the exercises hurt. She's got a way of making you feel like you can accomplish anything." Sarah noticed General Morrison studying the interaction with particular interest, her eyes moving between Sarah's face and her hands as she guided the patient through his exercises. The general's expression was unreadable, but her attention was clearly focused and analytical. As the tour moved on, Sarah heard fragments of conversation between delegation members. Some of the comments were predictable, discussions about equipment, staffing levels, and treatment protocols. But she also caught remarks about the hospital's patient-centered approach and the quality of care they had observed. The formal presentation was scheduled for 2 o'clock in the hospital's main conference room. Sarah arrived 15 minutes early, carrying her presentation materials and trying to calm her nerves. Dr. Hayes was already there, setting up the projector and reviewing her notes one final time. "How are you feeling?" Dr. Hayes asked as Sarah took her seat at the presentation table. Terrified and excited in roughly equal measure, Sarah replied honestly. "Good. That means you care about the outcome, which is exactly the right attitude for this kind of presentation." The delegation members began filing into the conference room precisely at 2 o'clock. General Morrison took a seat in the front row, flanked by 2 other military officers and a civilian researcher who had been taking extensive notes throughout the morning tour. Mrs. Coleman made the opening remarks, providing background information about the hospital's trauma care program and introducing the presentation team. When she introduced Sarah as the trauma care specialist who would be discussing patient recovery protocols, there was a noticeable shift in the room's attention. Sarah stood and moved to the podium, acutely aware that every eye in the room was focused on her face. She took a deep breath and began her presentation, her voice steady despite her nerves. "Good afternoon. I'm Sarah Martinez, and I want to talk with you today about trauma recovery from a perspective that combines clinical expertise with lived experience." She clicked to her first slide, which showed statistical data about facial trauma recovery rates at St. Mary's Hospital compared to national averages. The numbers were impressive. Their patients showed significantly better outcomes in multiple categories. "These statistics represent more than just medical success stories," Sarah continued. "They represent individuals who have had to rebuild their sense of self-worth and identity after suffering injuries that changed how the world sees them and how they see themselves." As she moved through her presentation, Sarah noticed that the delegation members were leaning forward, clearly engaged with the material she was presenting. General Morrison in particular seemed to be paying close attention, occasionally making notes but mostly listening intently. Sarah presented case studies of several patients, including Corporal Wilson, though she was careful to maintain confidentiality by using only initials and focusing on treatment approaches rather than personal details. She discussed the role that peer support and shared experience played in recovery, the importance of addressing psychological and social challenges alongside physical healing, and the measurable impact that specialized trauma care protocols could have on long-term outcomes. Traditional medical training teaches us to maintain professional distance from our patients, Sarah said as she approached the end of her presentation. But trauma recovery often requires something more than clinical competence, it requires hope. When patients can see that someone who has walked a similar path can still live a full, meaningful, and productive life, it gives them permission to believe that recovery is possible for them too. She clicked to her final slide, which showed a simple statement: scars are not the end of the story, they are evidence that the story continues. The room was quiet for a moment after Sarah finished speaking. Then, General Morrison raised her hand. "Ms. Martinez, thank you for that presentation. I have a question about the practical implementation of peer support programs in military medical facilities. How would you address concerns about maintaining professional boundaries while still providing the kind of personal connection that seems to be so crucial to your approach?" It was exactly the kind of question Sarah had hoped for: substantive, focused on the clinical aspects of her work rather than her personal appearance, and demonstrating genuine interest in the potential applications of her methods. "That's an excellent question, General Morrison," Sarah replied. "The key is establishing clear protocols that allow for authentic connection while maintaining appropriate professional standards. In our experience, patients respond best when they sense that their care provider genuinely understands their experience, but that understanding doesn't require disclosure of personal details or inappropriate emotional involvement." The discussion that followed was intense and detailed, with delegation members asking probing questions about implementation strategies, training protocols, cost-benefit analyses, and measurable outcomes. Sarah found herself answering questions not just about her own work, but about broader approaches to trauma care that incorporated psychological and social factors alongside traditional medical treatment. General Morrison asked several follow-up questions that demonstrated a sophisticated understanding of both military culture and medical care challenges. Her questions suggested that she was already thinking about how these approaches might be adapted for use in military medical facilities, where service members often faced additional challenges related to career impact and military readiness standards. As the presentation concluded, General Morrison approached Sarah directly. "Ms. Martinez, I'd like to speak with you privately if you have a few minutes," the general said. "There are some additional questions I'd like to discuss that might be relevant to future collaboration opportunities." Sarah felt a mix of excitement and anxiety as she followed General Morrison to a smaller conference room where they could talk without interruption. This was either going to be the opportunity of a lifetime or a polite rejection delivered in private to avoid embarrassing her in front of the delegation. General Morrison closed the conference room door and gestured for Sarah to take a seat at the small table near the window. The afternoon sunlight streamed through the blinds, casting long shadows across the room that somehow made the moment feel both intimate and significant. "Ms. Martinez," General Morrison began, settling into her chair with the practiced ease of someone accustomed to difficult conversations, "I want to be direct with you about something that I think you need to hear." Sarah braced herself, uncertain whether the general's tone suggested good news or bad news. "In my 30 years of military service, I've seen thousands of presentations about medical care, trauma recovery, and treatment protocols. Most of them blend together after a while, competent professionals sharing competent research with predictable results." The general paused, studying Sarah's face with an intensity that was both professional and personal. "Your presentation was different. Not just because of your personal experience with facial trauma, though that certainly added credibility to your message. It was different because you demonstrated something that we desperately need in military medicine right now: the ability to provide hope alongside treatment." Sarah felt a wave of relief mixed with anticipation. "Thank you, General. I hope that means you see potential applications for this approach in military medical facilities." "I do, but I also see challenges that we need to discuss honestly," General Morrison replied. "Military culture is complex when it comes to visible differences and perceived vulnerabilities. Service members who suffer facial trauma often face not just medical and social challenges, but concerns about their military careers, their ability to serve effectively, and their acceptance within military communities. The general stood and walked to the window, looking out at the hospital parking lot where staff members were coming and going at the end of their shifts. We've had increasing numbers of service members returning from deployments with facial injuries from IEDs, explosions, and other combat situations. Our current medical protocols are excellent at saving lives and providing immediate care, but we're failing at helping these men and women rebuild their lives afterward. She turned back to face Sarah. Last month, I visited Walter Reed Medical Center and spoke with a young Marine who had suffered severe facial burns during his second deployment in Afghanistan. He told me that the hardest part of his recovery wasn't the pain or the surgeries, it was feeling like he had become invisible to his fellow Marines, like they couldn't see past his injuries to remember who he had been before. Sarah nodded, recognizing the experience from her own life and from conversations with patients like Corporal Wilson. That Marine's words have stayed with me because they highlight a gap in our care that traditional medical training doesn't address. We can heal bodies, but we're not equipped to heal the sense of isolation and diminished self-worth that often accompanies visible trauma. General Morrison returned to her seat and leaned forward slightly. Your approach suggests a way to bridge that gap, but implementing it in military medical facilities would require overcoming some significant cultural and institutional barriers. What kind of barriers? Sarah asked. Military culture values uniformity, physical fitness, and what we sometimes call military bearing, the ability to present a professional military appearance. Service members with visible injuries often feel like they no longer meet those standards, and, unfortunately, some of their colleagues and superiors reinforce that perception through their reactions and treatment. The general's honesty was both refreshing and troubling. Sarah appreciated the directness, but she was also concerned about the implications of what she was hearing. Additionally, General Morrison continued, there are practical considerations about career advancement, deployment eligibility, and duty assignments. Service members with visible injuries often find themselves limited in their military opportunities, which can compound the psychological impact of their trauma. Sarah had been thinking about these challenges throughout her preparation for the presentation. General Morrison, if I may ask, what would you envision as the ideal outcome of implementing trauma recovery protocols that address these issues? The general smiled slightly, and, for the first time since they had begun talking, her expression showed something approaching enthusiasm. I envision military medical facilities where service members with visible trauma receive not just excellent medical care, but comprehensive support that helps them maintain their dignity, their sense of purpose, and their connection to military communities. I envision treatment protocols that recognize the unique challenges faced by service members and provide specialized interventions to address those challenges. She paused, gathering her thoughts. But, most importantly, I envision a change in military culture itself, a shift toward recognizing that visible scars can be evidence of service and sacrifice rather than signs of weakness or diminished capability. Sarah felt a surge of excitement at the possibilities the general was describing, but she also recognized the magnitude of what would be required to create such changes. That sounds like exactly the kind of work I've been hoping to become involved with, Sarah said. But I'm curious about something. You've been very open about the challenges and cultural barriers that exist in military settings. How do you think my own appearance and experience would be received in those environments? General Morrison's expression became more serious. That's actually one of the reasons I wanted to speak with you privately. I need to be honest about what you would face if you chose to work with military medical facilities. She leaned back in her chair, choosing her words carefully. Some military personnel would see your scars and immediately understand the credibility and insight you bring to trauma recovery work. Others would be uncomfortable, distracted, or even openly hostile. Military culture is changing, but it's changing slowly, and there are still many people within the system who struggle with differences that challenge traditional expectations. Sarah appreciated the general's candor, even though it wasn't entirely what she had hoped to hear. However, General Morrison continued, I believe that your experience and expertise are exactly what we need to create meaningful change. The service members who are suffering from facial trauma need to see that recovery is possible, that productive careers are possible, and that they can still be valued members of their military communities. You provide living proof of all of those possibilities. The conversation was interrupted by a knock on the conference room door. Dr. Hayes entered with an apologetic expression. "I'm sorry to interrupt, but there's been a development with one of our patients that I think both of you should know about," Dr. Hayes said. "What's happened?" Sarah asked, immediately concerned. "Corporal Wilson has been experiencing some complications with his recovery." "Not medical complications, his surgical site is healing well. But he's been having panic attacks and episodes of severe depression since this morning. He's been asking specifically for you, Sarah, and he's refusing to speak with the psychiatric staff." Sarah felt her heart sink. Corporal Wilson had been making such good progress that she had begun to think he was past the worst of his psychological struggles. "I'll go to him right away," Sarah said, starting to rise from her chair. "Actually," General Morrison said, "would it be possible for me to accompany you? I'd like to observe how you handle this kind of situation, if that would be appropriate and if Corporal Wilson consents." Dr. Hayes looked surprised by the request, but she nodded. "As long as the patient agrees, that should be fine. Though I should warn you that he's been quite agitated and resistant to having additional people around." The three women walked quickly through the hospital corridors toward the trauma ward. Sarah's mind was racing with possibilities about what might have triggered Corporal Wilson's setback. He had been stable for weeks, engaging actively with his treatment and showing steady improvement in his emotional state. As they approached his room, Sarah could hear voices through the partially open door. Corporal Wilson was speaking with someone in an elevated, distressed tone. "I don't care what the regulations say," he was saying. "I can't go back looking like this. I can't be around my unit with these scars. They won't be able to look at me the same way." Sarah knocked gently on the doorframe and entered the room. Corporal Wilson was sitting on the edge of his bed, still wearing his hospital gown but clearly agitated. Standing near the window was a man in military dress uniform who appeared to be in his 40s. "James," Sarah said softly, "I heard you were having a difficult day. What's going on?" Corporal Wilson looked up at her with relief clearly visible in his eyes. "Sarah, thank God. This is Captain Rodriguez, my commanding officer. He came to visit, and we were discussing my return to duty, and I just..." His voice trailed off as he noticed General Morrison standing behind Sarah and Dr. Hayes. "Corporal Wilson," Sarah said gently, "this is General Morrison. She's been visiting our hospital to learn about trauma recovery protocols. Would it be okay if she stayed while we talked?" Corporal Wilson looked uncertain, but he nodded. "I guess that's fine. Though I'm not sure how much of an example I'm being right now." Captain Rodriguez stepped forward and addressed General Morrison. "General, I'm Captain Miguel Rodriguez, Corporal Wilson's commanding officer. I've been trying to explain to the corporal that his unit is looking forward to having him back, but he seems to have some concerns about his readiness to return to duty." Sarah noticed the tension in the room immediately. Captain Rodriguez's words were supportive, but his body language and tone suggested discomfort, and Corporal Wilson was clearly picking up on that discomfort. "James," Sarah said, taking his seat in the chair next to his bed, "can you tell me specifically what you're worried about regarding your return to duty?" "It's not just the return to duty," Corporal Wilson replied, his voice shaking slightly. "It's everything." Captain Rodriguez was explaining the process for medical evaluation and duty assignment, and it made me realize that nothing is going to be the same. I'll probably be assigned to non-deployment duties, which means I won't be with my unit when they go back overseas. I'll be the guy who couldn't handle his injuries well enough to stay with his team." Sarah glanced at Captain Rodriguez, who was looking increasingly uncomfortable with the conversation. "James, let's talk about what handling your injuries actually means," Sarah said. "You've survived a traumatic event that could have killed you. You've undergone multiple surgeries, participated actively in physical therapy, and worked hard on your emotional recovery. That sounds like handling your injuries extraordinarily well to me. But that's not how the military sees it, Corporal Wilson replied. Captain Rodriguez explained that facial injuries affect deployment eligibility because of equipment fitting issues and potential complications in field conditions. He's right, these scars do limit what I can do in my military career. General Morrison had been listening carefully to the conversation, and now she stepped forward. Corporal Wilson, may I ask you something? She said. When he nodded, she continued. What made you decide to join the military? I wanted to serve my country, ma'am. I wanted to be part of something bigger than myself, to protect people who couldn't protect themselves. And, do you still feel that way? Yes, ma'am, but, then, let me tell you something, General Morrison interrupted gently. The military needs people who want to serve, people who understand sacrifice, and people who have proven they can overcome adversity. Your injuries don't disqualify you from service, they demonstrate that you've already given more for your country than most people ever will. She moved closer to his bedside. Yes, there may be some limitations on certain types of assignments. But there are many ways to serve, many ways to be part of that something bigger than yourself. The question isn't whether the military will have a place for you, it's whether you still want to be part of the mission. Captain Rodriguez was watching the interaction with a surprised expression. Clearly, this wasn't the conversation he had expected to witness. Captain Rodriguez, General Morrison said, turning to address Corporal Wilson's commanding officer, I'd like to discuss some new initiatives that are being developed for service members who have suffered combat-related facial trauma. There are opportunities for specialized assignments that would utilize Corporal Wilson's experience while accommodating any medical limitations he might have. The conversation that followed was unlike anything Sarah had expected. General Morrison began describing programs that were being developed to pair recovering service members with others who were going through similar experiences. She talked about opportunities for veterans with visible injuries to work in recruitment, training, and support roles that would allow them to share their experience and perspective with other service members. The military is beginning to recognize that diversity includes different types of experience and different types of strength, General Morrison explained. Service members who have been through combat trauma bring insights and credibility that can't be taught in any training program. As the discussion continued, Sarah watched Corporal Wilson's demeanor change dramatically. The panic and despair that had marked his expression when they entered the room was gradually being replaced by something that looked like hope and renewed sense of purpose. General Morrison, Corporal Wilson said after a long pause, are you saying that there are ways for me to continue serving even with these scars? I'm saying that your scars are evidence of your service, Corporal. They're proof that you were willing to put yourself at risk for your country and your fellow service members. In the military I'm working to build, that kind of evidence is valued, not hidden. Captain Rodriguez was listening to the conversation with growing understanding. Sarah could see that he was beginning to grasp concepts that hadn't been part of his training or experience, but that clearly made sense to him as both a military officer and a person who cared about the welfare of his soldiers. Corporal Wilson, Captain Rodriguez said, I owe you an apology. When I came here today, I was focused on the limitations and challenges you might face, and I lost sight of the strengths and experience you bring to our unit. General Morrison is right, you've proven your commitment to service in ways that most of us never will. The conversation continued for another 30 minutes, during which General Morrison outlined specific programs and opportunities that could provide career paths for service members with combat-related facial trauma. She discussed mentorship programs, specialized training opportunities, and leadership roles that would allow experienced service members to guide others through similar challenges. Throughout the discussion, Sarah found herself thinking about the broader implications of what she was hearing. General Morrison was describing exactly the kind of systemic change that could transform not just military medicine, but society's approach to visible differences and trauma recovery. As the meeting concluded, General Morrison asked to speak privately with Sarah again. They walked to a quiet corner of the trauma ward where they could talk without being overheard. "Sarah, I want to offer you an opportunity that I think could be life-changing for both you and the military medical community," General Morrison said. Sarah felt her pulse quicken with anticipation. "I'm developing a new program within military medical services that would focus specifically on trauma recovery for service members with visible injuries. The program would require someone with your combination of clinical expertise and personal experience to serve as a lead consultant and trainer." General Morrison paused, studying Sarah's reaction. The position would involve developing treatment protocols, training medical personnel, and working directly with recovering service members. It would be based at Walter Reed Medical Center, but it would also involve travel to military installations around the country and potentially overseas. Sarah felt overwhelmed by the magnitude of what was being offered. This was beyond anything she had ever imagined for her career. There would be challenges, General Morrison continued. You would be working in environments where some people might initially react negatively to your appearance. You would be representing new approaches to trauma care that challenge established protocols and cultural assumptions. And you would be pioneering a program that has never been attempted before. But, the general added with a slight smile, you would also have the opportunity to change the lives of hundreds, possibly thousands, of service members who are struggling with challenges that you understand better than almost anyone else in the country. Sarah felt tears forming in her eyes as she considered the possibilities. This was exactly the kind of work she had dreamed of doing, work that would transform her personal experience of trauma into a source of healing and hope for others. General Morrison, I'm incredibly honored by this offer. When would you need an answer? Take the time you need to consider it carefully, General Morrison replied. This would be a significant life change, and I want you to be certain that it's the right decision for you. But, I will say this, I believe you have the potential to revolutionize how we approach trauma recovery in military medicine, and I hope you'll decide to join us in that mission. As General Morrison walked away to rejoin her delegation, Sarah stood in the hospital corridor feeling like her entire world had shifted. Just hours earlier, she had been worried about whether she would be allowed to participate in a simple presentation. Now she was being offered the opportunity to lead a national program that could change the lives of countless service members. The irony wasn't lost on her that the scars she had spent years trying to overcome were now being viewed as qualifications for one of the most important opportunities of her career. Mrs. Patterson had been right, scars were indeed proof of survival, but they could be so much more than that. They could be sources of strength, wisdom, and hope for others who were fighting their own battles. Walking back toward Corporal Wilson's room to check on his progress, Sarah began to envision a future where her experience of trauma and recovery could serve a purpose larger than she had ever imagined. The challenges would be significant, but the potential impact was immeasurable. For the first time since her accident, Sarah began to believe that her scars weren't something to be overcome or hidden, they were tools that could be used to help heal others. The question now was whether she had the courage to embrace that possibility and step into a role that would put her visible differences at the center of her professional identity. 3 months later, Sarah found herself standing in the lobby of Walter Reed National Military Medical Center, carrying a briefcase filled with training materials and feeling a mixture of excitement and nervousness that reminded her of her first day as a nurse. The opportunity that General Morrison had offered had materialized into a formal position as Program Director for Visible Trauma Recovery Services, a newly created department within military medical services. The journey from that conversation in the hospital conference room to this moment had been both exhilarating and challenging. Sarah had spent weeks researching military medical protocols, studying existing trauma recovery programs, and developing comprehensive training curricula that would prepare medical personnel to work effectively with service members who had suffered facial injuries. The process had also required her to undergo extensive background checks, security clearances, and interviews with military officials who had varying levels of comfort with the program's innovative approach. Some interviews had gone smoothly, with officials who immediately grasped the potential value of peer support in trauma recovery. Others had been more difficult, particularly with senior officers who questioned whether someone with visible facial scars should be representing military medical services. One interview in particular had tested her resolve and forced her to articulate her vision more clearly than ever before. Colonel William Thompson, a career military officer with 30 years of service, had challenged her directly about the appropriateness of her role. "Ms. Martinez," he had said, his tone skeptical, "I understand that you have valuable experience and expertise, but I'm concerned about the message we send when we put someone with visible injuries in a highly visible position within military medicine. Our service members look to us for examples of strength and resilience. How do we know that your appearance won't undermine confidence in our medical capabilities?" Sarah had taken a deep breath before responding, drawing on months of preparation for exactly this type of question. "Colonel Thompson, I would suggest that strength and resilience are demonstrated not by the absence of scars, but by the ability to continue serving despite having been wounded. Every service member who has been deployed understands that injuries are a possible consequence of military service. What they need to see is that those injuries don't have to end their sense of purpose or their ability to contribute meaningfully to their communities and their country." She had paused, meeting his gaze directly. "My scars aren't evidence of weakness or failure, they're evidence that I survived something that could have destroyed me and chose to use that experience to help others heal. That's exactly the kind of resilience we want to model for service members who are facing similar challenges." The interview had continued for another hour, but, by the end, even Colonel Thompson seemed to understand the logic behind the program's approach. More importantly, he had agreed to support the pilot implementation at Walter Reed. Now, as Sarah prepared to begin her first day in her new role, she reflected on how dramatically her life had changed since that morning when Dr. Hayes had suggested she be hidden away during the delegation visit. The woman who had once been told she was too disturbing for patients to see was now about to lead a program that would train military medical personnel across the country. Her first task was to conduct an orientation session for the medical staff who would be working with the new trauma recovery program. The group included doctors, nurses, social workers, and mental health professionals who had volunteered to participate in the pilot program. Sarah had spent weeks preparing for this session, knowing that the success of the entire program would depend on gaining the support and cooperation of the medical staff who would be implementing the new protocols. The orientation was scheduled to take place in one of Walter Reed's main conference rooms. As Sarah entered the room, she saw approximately 30 medical professionals sitting around a large conference table. The atmosphere was professional but cautious. Clearly, people were curious about the new program but uncertain about what to expect. General Morrison was present to provide opening remarks and official support for the program. Her presence immediately signaled to the assembled staff that this initiative had high-level backing and should be taken seriously. "Ladies and gentlemen," General Morrison began, "thank you for volunteering to participate in this pilot program. As you know, we've been seeing increasing numbers of service members returning from deployments with facial trauma, and our current recovery protocols have proven inadequate for addressing the long-term psychosocial challenges these injuries present." She gestured towards Sarah. "Ms. Martinez brings a unique combination of clinical expertise and personal experience that we believe can significantly improve our ability to help these service members rebuild their lives and continue their military careers. I'll let her explain the specifics of what we hope to accomplish." Sarah stood and moved to the front of the room, immediately aware that every eye was focused on her scars. She had grown accustomed to this initial reaction, but the stakes felt higher here than they ever had before. "Good morning," she began, her voice steady despite her nerves. "I want to start by acknowledging something that I'm sure many of you are thinking about. Yes, I have facial scars from a traumatic injury, and, yes, that personal experience is relevant to the work we're here to discuss." She clicked to her first slide, which showed statistics about facial trauma recovery outcomes in civilian versus military medical facilities. These numbers tell us something important. Service members with facial injuries are experiencing higher rates of depression, anxiety, and career-related distress than their civilian counterparts with similar injuries. The question we need to ask is, why? Over the next 2 hours, Sarah presented research findings, case studies, and proposed interventions that address the unique challenges faced by military personnel with visible injuries. She discussed the role that military culture played in shaping recovery outcomes, the importance of peer support in building confidence and resilience, and the need for specialized protocols that addressed career concerns alongside medical treatment. The response from the medical staff was overwhelmingly positive. Dr. Amanda Richardson, a psychiatrist who specialized in trauma recovery, raised her hand during the question period. "Ms. Martinez, I've been working with combat veterans for 8 years, and I've struggled with exactly the issues you're describing. How do you envision implementing peer support when many of our patients are dealing with classified missions and security concerns?" It was exactly the kind of practical question that Sarah had hoped to receive, evidence that the staff was thinking seriously about implementation rather than just conceptual possibilities. "That's an excellent question, Dr. Richardson. We've developed protocols that allow peer supporters to provide emotional and practical guidance without requiring disclosure of specific mission details or classified information. The focus is on the universal aspects of recovery from facial trauma, dealing with changed appearance, managing social situations, maintaining confidence in professional settings, rather than on the specific circumstances that led to the injuries." The session continued with detailed discussions about training requirements, patient selection criteria, outcome measurement protocols, and integration with existing medical services. By the end of the orientation, Sarah felt confident that she had gained the support she needed to move forward with the pilot program. Over the following weeks, Sarah began working directly with service members who had been referred to the new program. Her first patient was Staff Sergeant Maria Santos, a 28-year-old Army specialist who had suffered severe burns to her face and hands during a vehicle explosion in Syria. Staff Sergeant Santos had been medically stable for months, but she was struggling with depression and anxiety that were interfering with her recovery. She had been resistant to traditional counseling approaches and was considering requesting discharge from the military rather than continuing with her treatment. When Sarah first met with Staff Sergeant Santos, the initial interaction was tense and challenging. Santos was clearly skeptical about the program and uncomfortable with the idea of discussing her injuries with someone she didn't know. "Look, I don't know what they told you about me, but I'm not interested in talking about my feelings or my trauma or any of that psychological stuff," Santos said during their first meeting. "I just want to figure out how to get through each day without people staring at me like I'm some kind of freak." Sarah recognized the defensive posture and the underlying pain that drove it. She had felt the same way during the early stages of her own recovery. "Maria," Sarah said, using her first name intentionally to create a more personal connection, "I'm not here to make you talk about anything you don't want to discuss. But I am here to tell you that I understand exactly what you mean about people staring." She gestured toward her own scars. 3 years ago, I was in a car accident that left me with these marks. For months afterward, I felt like everywhere I went, people were looking at me and seeing only my injuries. It was exhausting and isolating and infuriating." Staff Sergeant Santos studied Sarah's face with the careful attention of someone evaluating whether the person across from her truly understood her experience. "How did you get past it?" Santos asked quietly. "Honestly? I'm still working on it. But I've learned some things that help, and I've found ways to use my experience to do work that feels meaningful. That doesn't make the stares go away, but it gives them less power over how I feel about myself." Over the course of several sessions, Sarah and Staff Sergeant Santos developed a working relationship that was unlike anything Santos had experienced with previous counselors or medical personnel. Sarah's visible scars gave her immediate credibility, but, more importantly, her understanding of the practical challenges of living with facial trauma allowed her to provide guidance that was both specific and actionable. They worked on strategies for handling social situations, techniques for building confidence in professional settings, and approaches for dealing with the well-meaning but often insensitive comments from colleagues and friends. Sarah also helped Santos explore career options within the military that would allow her to continue serving while accommodating any limitations her injuries might create. The breakthrough in their work came during their fifth session, when Santos finally articulated the fear that had been driving her resistance to treatment. I keep thinking that if I accept help with this, if I admit that my injuries have affected me emotionally, then I'm proving that I'm not strong enough to be a soldier anymore, Santos said, tears running down her cheeks and soaking into the bandages that still covered part of her face. Sarah felt a deep recognition of that fear, having struggled with similar concerns about her own strength and resilience during her recovery.
Maria, let me ask you something. Do you think I'm weak because I sought help after my accident?
No, Santos replied immediately.
You're obviously strong.
You're here, doing this work, helping people like me.
Then, why would seeking help make you weak when it doesn't make me weak?
The question hung in the air for a moment as Santos considered it.
Because you're helping other people. That's different from just helping yourself.
But, how can I help other people if I never learned to help myself first? The strength you see in me now, the ability to do this work, to be comfortable talking about trauma and recovery, that came from accepting help when I needed it and working hard to rebuild my sense of who I was after my accident.
That conversation marked a turning point in Santos's recovery.
She began engaging more actively with her treatment, participating in physical therapy with renewed motivation, and exploring opportunities for continued military service that had previously seemed impossible.
More importantly for the broader program, Santos became an advocate for the peer support approach.
She began talking with other recovering service members about her experience, and several of them requested to be included in the pilot program. Word of the program's success began to spread throughout Walter Reed and beyond. General Morrison scheduled regular check-ins with Sarah to monitor progress and discuss expansion possibilities. During one of these meetings, the general shared feedback that confirmed Sarah's growing confidence in the program's impact. Sarah, I've been receiving reports from medical staff throughout the hospital about the changes they're seeing in patients who are working with your program, General Morrison said. Dr. Richardson tells me that Staff Sergeant Santos has shown more improvement in the past 2 months than in the previous 6 months combined. Sarah felt a surge of professional satisfaction, but she was also aware that the program's success was creating new challenges and opportunities. General Morrison, I've been thinking about how we might expand this approach beyond Walter Reed.
Are there opportunities to implement similar programs at other military medical facilities?
That's exactly what I wanted to discuss with you, the general replied. Based on the success we're seeing here, I've received authorization to expand the program to 3 additional facilities: Naval Medical Center San Diego, Brooke Army Medical Center in San Antonio, and Landstuhl Regional Medical Center in Germany.
The expansion would require Sarah to travel extensively, training new staff and establishing programs at each facility.
It would also mean working with different military cultures and medical systems, each with their own challenges and opportunities. The position would come with a promotion and significant increase in responsibilities, General Morrison continued. You would be overseeing a team of trainers and coordinators, developing standardized protocols that could be implemented across all military medical facilities, and representing the program at national conferences and policy meetings. Sarah felt overwhelmed by the scope of what was being offered, but also excited by the potential impact. The work she had started with a small group of patients at Walter Reed could potentially reach thousands of service members across the entire military medical system. There's one more thing I want to discuss with you, General Morrison said, her tone becoming more serious. This expansion would make you a very visible representative of military medicine and military values. You would be speaking at conferences, meeting with congressional committees, and representing the military's approach to trauma recovery in very public forums.
Sarah understood the implication.
Her scars, which had once been seen as disqualifying her from patient care, would now be prominently displayed in some of the most important venues in military medicine and policy.
General Morrison, are you certain that's the image the military wants to project?
I'm honored by your confidence in me, but I want to make sure we're being realistic about how I'll be received in those settings. General Morrison smiled with what looked like genuine pride. Sarah, over the past few months, you've demonstrated that strength and resilience aren't defined by the absence of scars, but by the willingness to use your scars to help others heal. That's exactly the image we want to project, that the military takes care of its own, that service-connected injuries are honored rather than hidden, and that our commitment to our service members doesn't end when they're wounded. As their meeting concluded, Sarah realized that her life had come full circle in ways she never could have imagined. The accident that had once made her feel broken and damaged was now the foundation for work that could transform military medicine. The scars that had once made her want to hide were now sources of credibility and connection that allowed her to reach people that traditional medical approaches couldn't help. Walking through the corridors of Walter Reed that afternoon, Sarah noticed that staff members no longer stared at her scars with discomfort or pity. Instead, they greeted her with the respect accorded to someone who was making a meaningful difference in the lives of patients and colleagues alike. The transformation wasn't just professional, it was deeply personal. For the first time since her accident, Sarah felt like her scars were truly part of who she was rather than obstacles to overcome. They were evidence of her journey, tools for her work, and symbols of the resilience that had brought her to this moment. As she prepared to take on the expanded role that would make her one of the most visible faces of military trauma recovery, Sarah understood that she was about to embark on the most challenging and important phase of her career. The work ahead would test everything she had learned about herself, her profession, and the power of using personal experience to create healing for others. But she also knew that she was ready for the challenge, armed with the knowledge that her scars were not signs of weakness to be hidden, but badges of honor to be worn proudly in service of something larger than herself. 2 years later, Sarah stood on the stage of the National Military Medicine Conference in Washington, D.C., looking out at an audience of over 800 military medical professionals, policymakers, and government officials. The conference was the most prestigious gathering in military medicine, and Sarah had been invited to deliver the keynote address about the transformative impact of peer support programs in trauma recovery. As she approached the podium, Sarah was acutely aware that this moment represented the culmination of a journey that had begun in the darkest period of her life. The scars that had once made her feel like hiding from the world were now prominently displayed before some of the most influential people in military medicine, and she was about to share research findings that could reshape how the entire military medical system approached trauma recovery. "Good morning," she began, her voice carrying clearly through the large auditorium. "My name is Dr. Sarah Martinez, and I want to start by sharing some numbers that I think will surprise you." The title doctor was new. Sarah had completed her doctorate in trauma psychology through an accelerated program specifically designed for military medical professionals. The degree had been challenging to pursue while managing her expanding responsibilities, but General Morrison had insisted that the additional credibility would be essential for the national leadership role Sarah was taking on. Over the past 2 years, military medical facilities implementing peer support trauma recovery programs have seen a 78% improvement in long-term recovery outcomes for service members with visible injuries. Depression and anxiety rates have dropped by 65%. Most significantly, career retention rates for service members with facial trauma have increased by over 200%. She clicked to her first slide, which showed comparative data from military medical facilities before and after implementing the new protocols. These numbers represent more than statistical improvements, they represent thousands of service members who have been able to rebuild their lives, continue their military careers, and contribute meaningfully to their communities after suffering injuries that might previously have ended their sense of purpose and belonging. The audience was clearly engaged, leaning forward and taking notes as Sarah presented case studies and research findings that documented the program's impact across multiple military installations. What made this presentation particularly significant was the audience it was reaching. Seated in the front rows were generals, admirals, and senior civilian officials who had the authority to implement policy changes across the entire military medical system. Also present were researchers from major universities, representatives from veteran advocacy organizations, and international military medical personnel who were considering adopting similar approaches in their own countries. The key insight that has driven the success of these programs, Sarah continued, is the recognition that healing from trauma, particularly visible trauma, requires more than medical intervention. It requires hope, which can only be provided by people who have successfully navigated similar challenges. She paused, looking directly at several senior military officials in the front row. For too long, military culture has treated visible injuries as evidence of weakness or diminished capability. Our research demonstrates that this approach not only fails to support our service members, it actively undermines their recovery and their continued ability to serve. The statement was bold, directly challenging traditional military attitudes that some in the audience still held. Sarah had debated whether to be so direct in her criticism, but General Morrison had encouraged her to present the findings without diplomatic hedging. Service members with visible trauma bring unique strengths to military communities. They understand sacrifice in ways that others cannot. They have demonstrated resilience under the most challenging circumstances. And they provide credibility when working with other service members who are facing similar challenges. Sarah clicked to a slide showing photographs of several service members who had participated in the program, with their permission and with their faces partially obscured to protect their privacy. Each photograph showed someone engaged in meaningful military work despite having visible facial scarring or other trauma-related injuries. Staff Sergeant Maria Santos, who you see here working as a training instructor, had been considering leaving the military after suffering severe facial burns during a deployment in Syria. Through the peer support program, she not only continued her military career but took on a leadership role in training other service members about trauma recovery. Her personal experience with facial trauma gives her credibility with trainees that no textbook or lecture could provide. The audience was responding positively to the presentation, but Sarah knew that the most challenging part was still to come. She had decided to conclude her remarks with something she had never done publicly before, sharing her own story in detail and connecting it directly to the policy recommendations she was making. Before I discuss our recommendations for national implementation of these programs, I want to share something personal that I think provides important context for understanding why this work matters so much to me. She clicked to a slide that showed a photograph of herself and her brother Miguel, taken just weeks before the accident that had changed her life forever. 5 years ago, I was a business student with no particular interest in healthcare or military service. My younger brother Miguel and I were driving home from a family dinner when a drunk driver ran a red light and crashed into our car. Miguel was killed instantly, and I was left with the facial scars that you see today. The auditorium had grown completely silent. Sarah had given hundreds of presentations over the past 2 years, but she had never shared this level of personal detail with such a large and influential audience. During my recovery, I experienced everything that our service members with facial trauma experience: the stares, the whispers, the well-meaning but painful comments from people who couldn't see past my injuries. I felt like I had lost not just my brother, but my identity, my confidence, and my sense of belonging in the world. She paused, gathering strength for what came next. The medical care I received was excellent, but what saved me was the hope provided by healthcare workers who helped me understand that my scars didn't define my worth or limit my potential. That experience led me to change my major to nursing, and eventually to the work I do today. Sarah clicked to another slide, this one showing her working with service members at Walter Reed Medical Center. I'm sharing this not to seek sympathy, but to illustrate a critical point about trauma recovery that our research has consistently confirmed. Healing happens not just through medical intervention, but through connection with people who can provide living proof that recovery and meaningful contribution are possible. She looked directly at the senior military officials in the front row as she delivered her next point. Every service member with visible trauma needs to see evidence that their injuries don't disqualify them from being valued members of their military communities. They need to see that scars can be sources of strength rather than shame, that visible differences can be assets rather than liabilities. The response from the audience was immediate and powerful. Sarah could see people nodding, taking notes more vigorously, and whispering among themselves. Several audience members were visibly emotional, clearly connecting her words to their own experiences with wounded service members. Our recommendations for national implementation focus on three key areas, Sarah continued, moving into the policy section of her presentation. First, mandatory training for all military medical personnel on trauma-informed care that addresses the psychosocial aspects of recovery alongside medical treatment. Second, establishment of peer support programs at every military medical facility that treats service members with visible injuries. Third, policy changes that recognize visible scars as evidence of service rather than barriers to continued military participation. The final recommendation was the most controversial, directly challenging military regulations that had historically limited career opportunities for service members with certain types of visible injuries. We are recommending that the military adopt new standards that evaluate service members based on their functional capabilities rather than their appearance, with specific protections for service members whose visible injuries are the result of combat or service-connected activities. During the question and answer session that followed, Sarah fielded inquiries from audience members who ranged from enthusiastic supporters to skeptical critics. One question came from Admiral Robert Chan, a senior Navy medical officer who had been vocal about his concerns regarding the program. Dr. Martinez, while I appreciate the positive outcomes you presented, I'm concerned about the practical implications of implementing these programs across all military medical facilities. How do we ensure that peer supporters maintain appropriate professional boundaries while still providing the personal connection that seems to be crucial to their effectiveness? It was exactly the kind of question that Sarah had expected and prepared for extensively. Thank you for that question, Admiral Chen. Professional boundary maintenance is indeed crucial, and we've developed comprehensive training protocols that address this concern specifically. Peer supporters receive 40 hours of initial training followed by ongoing supervision and continuing education requirements that exceed those of many traditional counseling programs. She clicked to a slide showing the training curriculum and oversight structure. The key is establishing clear protocols that allow for authentic connection based on shared experience while maintaining appropriate therapeutic boundaries. Our peer supporters are trained to share their recovery journey in ways that provide hope and guidance without inappropriate self-disclosure or role confusion. The questions continued for nearly an hour, covering everything from funding mechanisms to outcome measurement protocols to international implementation possibilities. By the end of the session, Sarah felt confident that she had addressed the major concerns and built support for the expansion recommendations. After the presentation, Sarah was surrounded by audience members who wanted to continue the conversation. Several senior military officials expressed interest in piloting the programs at their facilities. Researchers from major universities inquired about collaboration opportunities. Most significantly, representatives from veteran advocacy organizations approached her about extending the programs to civilian veteran populations who were struggling with similar challenges. Among the people waiting to speak with her was someone she hadn't expected to see at the conference, Mrs. Eleanor Patterson, the elderly patient who had shared her husband's story about war scars during Sarah's difficult early days at St. Mary's Hospital. "My dear," Mrs. Patterson said, approaching Sarah with a warm smile, "I saw the announcement about your presentation in the newspaper and simply had to come. I hope you don't mind that I've been sitting in the back, watching you change the world." Sarah felt tears forming in her eyes as she embraced the woman whose words had helped her begin to see her scars differently. "Mrs. Patterson, I can't tell you how much it means to see you here. Your husband's story about scars being evidence of survival, that insight has guided everything I've done since." "He would be so proud," Mrs. Patterson replied. "Though I suspect he would also say that you've taken his simple observation and turned it into something far more powerful than he ever imagined." Their conversation was interrupted by General Morrison, who approached with someone Sarah hadn't met before, a distinguished woman in civilian attire who carried herself with unmistakable authority. "Sarah," General Morrison said, "I'd like you to meet Secretary of Defense Patricia Williams. She's been following the development of your programs with great interest." Sarah felt a moment of shock at being introduced to one of the most powerful people in the Defense Department, but she quickly composed herself and extended her hand. "Secretary Williams, it's an honor to meet you." "Dr. Martinez, the honor is mine," Secretary Williams replied. Your presentation today was remarkable, and I wanted to speak with you personally about the potential for implementing these programs across all branches of military service.
The conversation that followed was unlike anything Sarah had ever experienced.
Secretary Williams spoke knowledgeably about the research findings, asked probing questions about implementation strategies, and demonstrated a sophisticated understanding of both the military culture challenges and the potential benefits of the programs.
Dr. Martinez, I want to be direct with you about something, Secretary Williams said.
The Department of Defense is prepared to commit significant resources to expanding these programs, but we need assurance that they can be implemented consistently across all military installations and all service branches.
Sarah felt the weight of the moment.
The conversation was moving toward a national commitment that would affect thousands of service members and potentially reshape military medical policy for decades to come. Secretary Williams, I'm confident that the programs can be scaled effectively, but successful implementation will require strong leadership support at every level and a genuine commitment to changing aspects of military culture that have historically stigmatized visible differences.
That's exactly what I wanted to hear, Secretary Williams replied.
We're prepared to issue policy directives that mandate implementation of these programs and provide the cultural support necessary for their success. But we need someone to lead this effort nationally, someone with the credibility, expertise, and personal commitment to ensure that the transition is successful. Sarah realized that she was being offered another life-changing opportunity, one that would take her work to a scale she had never imagined possible.
Secretary Williams, are you offering me a position within the Department of Defense?
I'm offering you the opportunity to serve as the first Director of Military Trauma Recovery Services, a new position that would oversee implementation of peer support programs across all military medical facilities worldwide. The position would come with significant authority, substantial resources, and the mandate to create systemic change in how the military approaches trauma recovery. As Sarah considered the magnitude of what was being offered, she thought about the journey that had brought her to this moment. From a young woman studying business with no particular interest in healthcare, through the trauma of losing her brother and acquiring facial scars, through the challenges of becoming a nurse while facing discrimination and rejection, to this opportunity to transform military medicine on a national scale.
Secretary Williams, I'm deeply honored by this offer. When would you need an answer?
Take the time you need, but I hope you'll consider that this represents an opportunity to impact the lives of every service member who suffers visible trauma in service to our country. Your personal experience, combined with your professional expertise, makes you uniquely qualified to lead this effort. As the conference concluded and attendees began to disperse, Sarah found herself surrounded by people who wanted to continue discussions about implementation, collaboration, and expansion possibilities. The work she had started with a small pilot program at Walter Reed had grown into a movement that could reshape military medicine and military culture. Walking through the conference venue that evening, Sarah reflected on how different her life had become from anything she could have imagined 5 years earlier. The scars that had once made her feel damaged and diminished had become the foundation for work that was now being recognized at the highest levels of government and military leadership. More importantly, she had learned that healing, both her own and others, wasn't about erasing scars or pretending that trauma hadn't occurred. It was about integrating those experiences into a larger story of resilience, service, and contribution to something greater than oneself. As she prepared to leave the conference and return to Walter Reed to continue her work while considering the Secretary of Defense's offer, Sarah understood that her journey was far from over. The challenges ahead would be significant, implementing programs across a massive bureaucracy, changing entrenched cultural attitudes, and maintaining the quality and integrity of services while rapidly expanding their reach. But she also knew that she was ready for those challenges, supported by colleagues who shared her vision, guided by research that proved the effectiveness of her approach, and motivated by the knowledge that her work could prevent other service members from experiencing the isolation and despair she had once felt. The scars on her face would always be visible, but they were no longer sources of shame or limitation. They were badges of honor, tools for connection, and symbols of the transformation that was possible when personal pain was channeled into service to others. In accepting her scars and using them to help others heal, Sarah had discovered that her greatest perceived weakness had become her most powerful strength. The little girl who had once been told she was too disturbing for patients to see had become a national leader in trauma recovery, proving that sometimes the most profound healing comes not from hiding our wounds, but from allowing them to become sources of light for others walking similar paths through darkness.